thank you. I have to say a lot of the comments actually resonated, and we would all have multiple occasions where we could talk about similar things that have happened, unfortunately. But communication in nursing, if I actually went into a large group of people and said, do you think nurses communicate well? I'm really confident that overwhelmingly people would say yes. Because generally I think there's some pretty amazing work that happens on a day-to-day basis. But tonight, of course, is about the issues, not about the great stuff, but the issues. And so I probably will come across as potentially a little bit critical, but that's not my intent. But it is to actually just highlight that, with the good is the not so good as well. So, when we do think about communication, especially within our health sector, we know that we have an issue because our organisations actually spend millions of dollars every year sending clinicians off to training programs to increase their communication skills and their abilities to work together as a team. So I think that in itself actually says a lot that while we do some things really well, there is still room for improvement. So what are the issues? When we think about the obvious culprits, it's, we have diverse backgrounds, educational, personal, our training backgrounds are quite different, and we all come together and coalesce into a big melting pot. Our cultural differences and values, and this actually plays a really important role, especially in situations where there are challenges to, very senior clinicians. Culturally, some people just will not challenge. So that can also prove difficult. Looking at English as a second language is really important when we consider our patients and their families. It is also relevant for our clinicians, but our patients and families that are non-English speaking or have English as a second language really do suffer at times from maybe our lack of understanding and need to actually reframe things for them. Generational communication styles and expectations, it's changed, from when I started nursing to where we are today. Things have changed a lot, and some of them are really good changes, but again, with change you sometimes lose some really valuable things along the way. Environments that are unfamiliar. Our nursing workforce is often required to, at very short notice, go relieving into unfamiliar areas to fill a gap. And that in itself poses a major risk because often they may not be in an area that they're used to working in, they don't know the procedures, policies and what is normal. So straight away, we actually increase the risk for our patients. Looking at change, lots of change. It's never going to go away. We've all learned to deal with it, but I think certainly over the last 5 to 10 years, it has been really significant in this state. And, I think clinicians need to be congratulated for keeping a stiff upper lip and moving forward in sometimes very adverse circumstance. And the introduction of new systems. So EPAS, I'm going to put that word out there. Love it or hate it, it has an impact on the way we communicate. So that's something to think of. When I was asked to speak about this, I actually started talking to quite a lot of clinicians and asking them, what they felt were the communication issues within nursing. And a couple of themes actually came through, and I'm going to bulk them under two strange titles, I suppose. One is honesty and the other one is assumptions. So honesty, what am I talking about there? Communication issues in nursing. Straight away people went to, we are offering a patient-focused service. It's a patient-centred service. And when I unpacked that a little bit more with people and said, well, what does that actually mean? Quite a few actually said, well, actually, in a lot of cases, it actually becomes a bit of a tick box. And an example of that would be our bed-to-bed handovers or rounding, where the expectation, certainly of our health department, is that we are actively involving our patients in the handover and discussion at every shift change. Now, in reality, what many of us see, that does happen in some wards, and people, do a fabulous job with that, actively engaging the patient. In a lot of circumstances, what we do see is groups of clinicians standing at the end of the bed or out in the corridor talking about the patient who's actually there, and at the very last minute say, have you got any questions? All right, thanks, and we'll be off. So if we're honest with ourselves, are we actually offering patient-centred care? Is that patient-centred communication? And we're all busy, and I think in the busyness of it sometimes we forget that taking the extra, minute or two to engage with someone can actually save us a lot of time down the road, where we are actually getting first-hand relevant information from the person most affected by the journey, which is the patient. Another issue that came through quite a bit around honesty was that nurses do this particularly poorly, although they are not the only discipline, and that is the difficult or conflict conversation. So not getting on with, Joe Bloggs who you're working with, and there may be professional issues, there may be that it is a personality clash, or that, there has been a breakdown in what's happening. And people are often a little bit hesitant to start that conversation. We don't look for conflict as a group. We like to, all be happy and friendly and get along. And generally that can work well. But we know that there are times where we do have to step up and have that difficult conversation. People will back off because, in spite sometimes of the way that you try and deliver that information, and let's face it, we don't always do it well, sometimes it's quite clumsy, the recipient can actually personalise it straight away. So you go from having a professional reflection discussion to it's personal, and everyone shuts down. That then actually causes more tension between the parties and decreases the communication again across. And we've actually had circumstances where people have actually withheld information rather than actually go and talk to the person that they've actually had the conflict with. So again, are we being honest in our communication and the way we actually interact with each other? Assumptions. This is something I think we all at times are guilty of. And one of them when communicating is that when we're delivering directions, we assume that the people on the receiving end are, number one, actively listening to us, or secondly, that they actually understand what has been said. So this comes back to the whole, senior, novice practitioner and clinicians, where to the senior, the direction is completely clear, it's crystal clear. They know what they're meaning, they're using all the jargon. Often health practitioners love a good acronym. We can fit 10 into a sentence if we're allowed to. And sometimes less experienced staff don't have the confidence to ask, can you explain that again? They may have been a little bit frazzled by the workload. They're at the third patient, they knew nothing about the last two, so he's going to ask me about this third one. So they're already frazzled and have probably missed the first half of the sentence. And a really simple way of actually addressing this and not assuming that the person's got the message is by using something through systems that our government pays for, which is team steps, and a lot of you would have done a team steps program, and using the check back mechanism. So can you just tell me, do you understand what I'm asking for? Can you just relay it back to me? A really simple technique. We know it works exceptionally well when it's used, and yet we seem to be a little bit hesitant to do that. And I'm not quite sure whether it's because we're all trying to be ever so polite to each other and we think people will take offence. A check back is not, I don't have faith in you. It is purely just, I want to make sure that you actually interpret my message. When people misinterpret the messages, we know the outcomes for our patients can actually be catastrophic. So, it's a good thing to do. The other thing that people talked about a lot was the multidisciplinary team. And if I ask you all, do you work in a multi-D team? Does everyone here would say, yeah, they work in a multi-D team? And they can be really effective. However, the risk with a multi-D team that I can see is that we can be working in multi-D silos, and we only actually link up when we want to hand over information, directions, etc. So that then means that we have a situation whereby people can actually, fall off the radar and messages don't actually come through. I think we would be better moving, and there's a lot of stuff out here about interdisciplinary teams and the need to actually look at the medical, the nursing, the allied health components coming together in a common goal. Everyone's responsible for that patient. The patient needs an IV and the intern can't get to it. Someone else needs to step up and get that sorted for the patient, not just assume, I've told someone, they're going to get to it. So when you're thinking about your teams, think about, are you working in a multidisciplinary team or are you working in an interdisciplinary team? And if it's not interdisciplinary, I would really encourage you to start exploring and moving down that line. Thank you.